Welcome to Old Friends, Part 2. In this unit, we're going to be looking at the assessment and management of patients over 65. Our patient assessment process is assisted by material from the GEMS program. GEMS is a course that was developed by the American Geriatric Society in combination with the National Council of State EMS Education Coordinators and a coalition of 13 other national organizations involved with EMS. The G in GEMS Diamond stands for geriatric patient. We know that older patients have unique presentation and needs of their own. Environmental assessment is E, and environment can give us many good clues as to patient's lifestyle and underlying condition. Medical assessment is particularly key in the geriatric patient. Part of getting a good medical history will also include going through their medications and knowing what they have access to, prescribed to, what they use, and what the purposes of those medications are. And the S, also very key for geriatric patients, is a social assessment. What you want to do is evaluate the patient's social network, and from that also get an idea of who can help you assess this patient better. That's the GEMS Diamond. As in every case, we're going to look at scene safety, and we'll want to think about the hazards that this patient is living with. Are there tripping hazards, burning hazards? Are there unsafe conditions in the house? Does it look like this person has been neglected and abandoned, or in fact are they going about their daily living activities without difficulty? You can get those kind of clues from the environment. Find out who can tell you more about the patient's history so you know what their baseline is in the event of altered behavior or altered mental status. In evaluating possible trauma, the mechanism of injury can be very important to possibly to give you an idea, is this a medical problem that developed into trauma, or is this a traumatic event that now has a patient who has a medical history, and that may also complicate things. In trauma systems, it's been shown through research and audits that being over 55 is a comorbid factor. It should be a reason to move a person ahead into the trauma system with a higher index of suspicion. However, frequently the elderly patient is under-triaged. When you're doing your scene size-up, it may sometimes be difficult to determine just what the nature of illness is. And even as you start to talk to the patient and obtain a history, complaints may be vague. It's important to remember that there are certain conditions that are high in severity and often hard for the patient to articulate. So conditions of chest pain, shortness of breath, and any altered level of consciousness should generally be regarded as serious and never be regarded as a attribute of aging. In our primary assessment, as always, we will want to address life threats and get a general impression of this patient so that we can make the right trajectory of care and transport them appropriately. In doing that, you're going to look at mental status. Confusion is not a norm. However, it is a frequent finding, and sometimes it's difficult to tell confusion from just slow recall. So you want to be sure and be patient with your patient as they're speaking with you, and listen for their ability to formulate a memory of what they're trying to respond to if you've asked them a question, and try to distinguish chronic changes from new ones. Often that really requires that you talk to family, bystander, caregiver, somebody who can help you establish what their baseline mental status is. In general, avoid making assumptions. As we look at the airway and breathing, expect anatomic changes to pose a little bit of a problem, particularly with ventilation. The tissues of the cheeks and mouth are softer, more pliable, and less able to resist the flow of air, and often will kind of make it a little more difficult for bag valve mask ventilation. So they have increased difficulty in mask seal. There also may be airway problems with the dryness of the mouth, dentures, and difficulty sometimes in even chewing their food. Be concerned about foreign object body airway obstruction. In assessing circulation, remember that the patient's medication may certainly affect your findings. And poor perfusion is a serious issue. Vascular changes, however, are not unusual for the elderly patient. It is going to be a challenge to move on into your secondary survey and a focused physical and focused history. The issues that usually come up are complicated medical backgrounds, communication issues in terms of sensory issues, being hard of hearing or having difficulty with vision, and the effects of multiple medications. All of these are things that you're going to weed through as you assess the elderly person. Common assessment pitfalls are inability to get a good, reliable history that is often made worse by showing disrespect. Even just the slightest movement of the eyes can sometimes make the patient become much more self-conscious of the fact that they are a burden to you, and they would just as soon not even bother to talk to you or waste your time. So watch for that. And always remember to use the patient's name frequently, particularly their surname and a respectful address. Look into their chief complaint, even though they may try to pawn it off or talk about other issues. Often this is the best time the patient has to talk to anybody. They may have a lot of things to say, not all of it germane to the reason they called you. So you want to get back to that chief complaint as best you can, respectfully, and be really thinking about things like getting all their medications, accounting for whether they take them regularly or not, knowing when their last meal was. That can be very important with blood sugar issues, but frequently the elderly also underhydrate themselves. So get an idea of their fluid status and how well they've been keeping up on fluids. As we talk to these people, think about therapeutic communication. Are you using active listening? Are you showing the patient respect and giving them time to answer questions? And do you have a little empathy for their situation? It's a realistic fear that going to the hospital may result in not being able to return home. This is the mindset you want to put yourself in as you try to think about what it's like for that patient to be having to call you and use your services. Think about what it's like for them, and that is probably one of the most underlying frequent fears, is they're not coming back to the home and the activities that are now a part of their daily life that they are valuing. And remember that they function every day on the edge of being able to or not being able to, and so that is another realist. Your physical exam is often going to be complicated by multiple layers of clothing and a feeling of being modest. Many people are kind of, what am I trying to say? They're not very proud of the condition that their bodies have deteriorated into, and as a result, they're going to be a little self-conscious about that. They're also going to be pretty sensitive to temperature in the fact that they have less insulation in the skin, so be cognizant of that as you make sure that you give them an opportunity to be examined in a warm and private environment. In checking vital signs, a few things to keep in mind. Heart rates are often affected by medications. Irregular pulses are common for a variety of reasons, including the possibility of atrial fibrillation. And circulatory compromise may make it hard to find a radial pulse. This may be because of their medication or because of atherosclerosis. And a couple of other things. Don't be surprised if you're dealing with some high blood pressure. Remember that cap refill is usually not a good assessment because of decreased peripheral circulation with age, while respirations and the importance of breath sounds do not change in any way between older patients and younger patients. Older people may have loss of a social network, or at least some decrease in their social networking. This is often made worse by the death of close friends or family members. They may also need assistance with frequent activities, so trying to get an idea of who provides that and how regularly they see this patient may be very helpful to you in determining the extent of their illness and the extent of their independence. Consider also in treating people who are of the elderly age group, pamphlets for agencies that you know of that can help them, particularly with food and work around the house. Acute coronary syndrome. There are 3 categories of patients who will give you atypical signs of a heart attack, and those are the elderly, females, and patients who are diabetic. Don't be surprised if you'll get all 3, and don't be surprised if they've lived to a large old age with heart attacks that they had. Key symptoms that you're going to be watching for are abdominal pain, not chest pain, sudden weakness, weakness without explanation, sometimes described as dizziness, and sometimes accompanied by dizziness, fatigue and confusion. Sudden confusion can be from a lot of things, but don't overlook the fact that it could be a sign of an acute coronary situation and the patient is in fact having a mild. Congestive heart failure is a common issue with many people because of their age, and yet it's not caused by old age. It's just frequent in there. We know that the risk factors that typically set somebody up for heart failure, number 1, are hypertension and also coronary artery disease, possibly previous heart attacks, and this is all exacerbated by rhythm disturbances, including atrial fibrillation. Look for dyspnea on exertion or reports of suddenly waking up in the middle of the night. For often it could be because of bladder, they feel like they need to go to the bathroom, or they just couldn't sleep well. And if you hear reports of that, find out if in fact they found themselves short of breath and that that's improved after they sat up or walked. They may also show you signs of anxiousness and fatigue and increased respiratory rate, partly due to the fact that they're looking at pulmonary edema, and those are all signs of left heart failure. One of the neat things is that many patients will be able to overcome the issues of aging by regular exercise. And I just wanted to kind of illustrate that with this gentleman here, the oldest known marathon runner in 2011. He was recognized in Toronto as the Turbaned Tornado. Last year he actually ran his last marathon reportedly, and is said that he was going to miss it greatly, but he continues to run daily. Stroke is a leading cause of death in the elderly. Stroke is definitely an issue that we want to be able to treat as a true emergency. It has preventable risk factors, including smoking, obesity, and sedentary lifestyle. Without these, people will go a lot longer without a stroke, but high cholesterol and hypertension are other risk factors that are very difficult to control once they're there in patients over 65. Uncontrollable factors, of course, is they may already have cardiac disease, You will look for headache, dizziness, loss of focal neurological control, often weakness in one hand or inability to use a hand, any focal loss in control from the brain, such as inability to move the eye, hand, face, slurred speech. Hemorrhagic strokes are less common and much more dangerous, and unfortunately more frequent in older patients. Ischemic strokes are still a majority in most age groups, and even in the patient who is over 80, there is a reason for hope that much of their mental capacity can still be salvaged. And that is because of some of the great advancements in removing clots from the brain tissue. Dementia is another issue. This is the slow onset of progressive disorientation, shortened attention span, and loss of cognitive function. Often this is attributed to Alzheimer's. However, there are a few other disease processes that are part of dementia or that bring about dementia. Normal aging is not a cause of dementia. Dementia could also be caused by cerebrovascular accidents, by strokes. Although Alzheimer's disease develops differently for everybody, there are many common symptoms, and for every individual that gets it. The symptoms early are mistaken to be some common age-related concerns, such as forgetting where you put your keys or forgetting somebody's phone number who just gave it to you. These are usually like short-term memory loss. When Alzheimer's is suspected, usually the physicians will order some tests and evaluate behavior and thinking. There is often a change in cognition. In other words, ability to reason and decipher stuff. That's usually another way that they test for that. As disease advances, symptoms include confusion, irritability, sometimes aggression, mood swings, trouble with language. About a third of these people will develop something called sundowner syndrome, where they're much more irritable and confused in the late hours of the day, and usually do much better during bright sunlight. Gradually, bodily functions are lost, and it is a fatal disease. It's a disease that is uncurable, and treatments are usually aimed at trying to deal with the memory loss. We know that we can slow down the progression of the disease with certain exercises. Actual cause is not really well known. One of the theories is that we actually see some hereditary problems with that, but that's only been proven in about 1 to 5% of the people who have it. Delirium is a sudden change in mental status, consciousness, or ability to think, and it usually starts with difficulty to focus, think logically, and associated with acute anxiety. This affects almost 50% of people who've been hospitalized over the age of 70. Delirium is usually a reversible cause, so this is not the same thing as dementia, and this is one of the things that EMS people want to tell the difference. Is it a type of dementia such as Alzheimer's, or is it delirium, which is often acute and often associated with a trackable and treatable cause, including alcohol withdrawal, alcohol intoxication, other medication effects, and again, withdrawal, particularly from sedatives. Sometimes it's also a manifestation of an acute coronary syndrome, a little more often than that, and a manifestation of a urinary tract infection. So in the patient's history, you want to find out if they do have a history of previous problems with memory, or if they have any psychiatric disorders. Always evaluate these people for hypoxia, for fluid status, tilt tests may be indicated, and blood glucose levels. It's probably pretty frequent that you're going to encounter a patient who has some type of drug interaction issues, or over-medication or under-medication issues if they're over the age of 65. A number of reasons for that. Medications are metabolized in the body, and then those metabolites are removed by the kidneys or filtered by the liver, and older people have issues with both of those. 29% of geriatric medications will be taking over 5 prescription medications. That goes up to over 5 is 36% of people over 75. So now there's 29% of people over 65, but 36% of people over 75 are going to have 5 or more, often even 10 medications that are prescribed. And by medications, I also mean some over-the-counter supplements, vitamins. Many patients will also choose to look for some herbal remedies as well as over-the-counter remedies that can interact with some of the medications they take. It's not unusual, too, for patients to see multiple physicians. Unfortunately, many of our older patients are not very good historians and may not be able to give their complete medical history when they're talking to a new physician. And if that new physician doesn't have their complete drug list, it's not impossible for them to order a medication that may have already been ordered, or may be combined with something they're already taking, or in fact be inappropriate for combination with those other medications. There's a lot of reasons why people who are on a fixed income may choose to be non-compliant. They may be financially challenged. The medications that the physician has prescribed or they think have found to be best for them are not on the pharmacopoeia, on the list that their insurance company has approved. They may have difficulty in opening the caps that are provided. They may have some visual problems when they're trying to sort out their medications. They might be taking the wrong one. Advice about the medications. They may pick the wrong med because they didn't hear it right. Our next topic is going to be trauma. And when you're thinking about trauma, remember that it's the leading cause of death up to age 44. Well, that does not mean that there's less trauma in the later years. It just means that they have other things to die of besides trauma. So we say trauma is the leading cause of death between ages 1 and 44. It remains a pretty significant issue for many people at all ages. Now, there's a lot of things about being over, being over 65 or 70 that tends to set you up for a traumatic event. You have weaker compensation mechanisms. They may be slowed down by medication. You have limited physiologic reserves, so it's harder to actually respond to illness very well. Your body's kind of already stressed. And then there may be some pre-existing medical problems that you're dealing with. As far as getting into trauma, there's a lot of reasons why in motor vehicle collisions that can happen. Decreased hearing and vision, confusion, impairment by medications, and occasionally other medical problems such as hypoglycemia or even stroke may cripple a person before they're having the accident and cause the accident. So, you take the keys, and people are going to discover that as being one of the worst things that's ever happened to them. They value their independence as much as life itself, and that's the American way. So you can't fault people for trying to get out and get around, and watch out, because sometimes the way they try to get out and get around may be totally inappropriate and result in more trauma, injury to themselves. Now, finding what's wrong with them is sometimes going to be subtle, and a thorough exam is going to be necessary. As I mentioned before, that may be challenged a little bit by the layers of clothing they have, or by the fact that when you're looking for pain response, they may not give you very much response at all. Remember that it doesn't take a large mechanism to cause injury to an older patient. And as I said before, many injuries end up being under-triaged and undertreated. Trauma can also be made worse by the fact that there's pulmonary and cardiovascular and neurological changes, and the musculoskeletal system also makes the patient much more susceptible to fractures and more disability as a result of those injuries, often because of poor muscle control. And exercise, again, is key to health. Falls are a common mechanism of injury, and this is another reason why our scene survey needs to include looking for ongoing hazards so that we don't get frequent calls for these reoccurring falls. Problems that help or that hinder the patient and end up making it more likely for them to have a fall include some of their sensory deficits and also their strength deficits, but often it's a lack of proprioception, and this is improved with certain exercises. Falls may result from fainting, from cardiac rhythm problems, or from the medication problems. So always assess when a patient tells you they fell, how they felt before they fell, what they remember about the fall, and if they can give full account of when they actually made contact with the ground, what they fell on, how it felt. Whenever, when you assess a fall patient, knowing what happened first may tell you whether you have a mixed trauma medical system. As a result of osteoporosis, many patients are going to be more prone to fractures after they fall, and one of the worst areas is the hip. We know that contributing factors toward osteoporosis include stress, includes vitamin D deficiencies, calcium deficiencies, metabolic bone disease, but for many people it's also just the hormones and changes in the body that result from aging. As you look at the shape of a patient with scoliosis or kyphosis and consider putting him on a flat backboard, you'll realize right away that that just will not be comfortable, nor will it be effective for immobilization without a whole lot of padding. Here's where vacuum immobilizers are probably more appropriate. The patient lay on the mattress of your stretcher in such a way as that they're in the position of comfort. Elderly patients are at also risk for pelvic fractures, and remember that can also result in a significantly high volume of blood loss, and especially if there's a risk of an open book fracture. So pelvic splinting or pelvic binding may be very appropriate. Also, don't overlook the fact that the spine will also be susceptible to compression fractures during falls, especially falls from significant heights. One thing you must never overlook is if the patient had altered mental status associated with their fall, did that occur afterward? Did it occur during? Any blow to the head, we need to be thinking about the possibility of a subdural hematoma or other hematomas in the brain, but certainly the subdural is a high probability. As with the aging process, the brain shrinks and the bridging veins between the brain and the dura mater are a little stretched and susceptible to fracture. And then if the patient also happens to be on a blood thinner, such as Coumadin, that hemorrhage is going to accelerate a little bit, and that subdural hematoma is going to grow and expand very quickly and unabated. So I mentioned earlier that certain exercises have been shown to really help with falls, in particular exercises that really encourage or get the patient to move their joints. I picked this picture of people doing Tai Chi because most of the time when you see Americans practicing Tai Chi, it's not like in Asia at all, where they really like to get deep and close to the ground. The more that we help elderly people do exercises like this, the more they're going to be kept from the fall issue. This has been proven to be very effective. Tai Chi Chuan and yoga are two of the exercise programs that really have been shown to help prevent falls and help people live much longer into their old years before falls become a. So I mentioned earlier about the risk of a subdural, and that's illustrated in this picture here. And remember also that long-term abuse of alcohol makes that brain even smaller. In general, elderly people are a little more likely to experience a variety of traumas because of altered mental status, altered attention, or altered sensorium. In other words, their senses aren't quite working well for them, including the sense of touch. Risk of burn mortality is also significantly increased in the older patient for the reasons that we've listed here. Internal temperature regulation is slowed, and many patients who are going to have trauma are also going to become hypothermic and may have hypothermic coagulopathies on top of any of the coagulation problems they may have from their medication. Which kind of brings me to environmental issues. It's interesting that half of all deaths from hypothermia occur in the elderly, and death rates from hyperthermia, from high temperature, are more than doubled in elderly people. At some point in your career, and probably you've done it a lot already, you're going to be going to nursing homes. And in nursing homes, we know that the most frequent thing we have to say about them is that we don't always find the staff to be extremely attentive and helpful to us when we're trying to get more information about our patient and take them out. At least that seems to happen more often than not, and that's often because staff are spread very thin in the nursing homes that most elderly people are able to afford. The other important aspect of responding to a nursing home is recognizing that you could be a carrier of highly infectious microorganisms. At the same time, these are the perfect breeding grounds for microorganisms that resist a lot of our medications. And this is where MRSA was developed. This is where your vancomycin-resistant enterococci have developed, is from patients that have been placed in nursing care. And RSV and Clostridium continue to be major problems. The new one is CRE. CRE actually kills about half the people who become infected with it, and it's so resistant to all known wide-spectrum antibiotics that it's really becoming a nightmare. People don't know how to treat it. One of the great pleasures that I've had with picking up patients from nursing homes and from home that are of this generation is that they have lived through some amazing times. In particular, if you think about the World War II veteran, that generation, people who've lived through that era, they grew up during the Depression, they fought the Great War, they saw the entire country mobilize, and have seen so many technological changes since then and have become a key part of it all. They have incredible work ethic, and they are usually very patient with caregivers, very appreciative of what we do. And if you take the time to visit with them, you almost always get a rewarding story. I know that in dealing with veterans, I have often found that they will share with me things, especially World War II veterans, that they have never in 50, 60 years shared with their spouse or with their own children because of a bonding with somebody who's another first responder. And I project that you'll probably encounter the same thing with Korean War vets. I think I've had that at least once or twice, and also with Vietnam vets. Patients who are at a point in their life when they know that death is coming and death is imminent often start to make important decisions. And if they want to die at home, they have that right, and they make that choice. Often they'll make sure that their family knows what their wishes are in terms of resuscitation, and occasionally family members will want to try and override that, which is laws concerning advance directives. Any patient who is mentally competent, and that includes emancipated minors, even have the right to determine their treatment and to decline treatment if they're incapacitated by recording it in an advance directive. If they've shared this with their physician, they actually write a do not resuscitate order. So to clarify, there are do not resuscitate orders. These are signed and ordered by a physician and should be honored because the physician-patient privilege means that the patient was aware, apprised, and in consent of that decision. If a physician order is not available, but the patient has signed an advance directive, or a CPR directive as it's referred to in some states, this does not require a physician signature, but does merely require a signature of the patient. Sometimes the actual original form that's signed can get misplaced or lost, and it is legal to accept that from a good copy, particularly if there is a family member who is there to support it. In situations where we're not sure what's going on, contact medical control, because legally our responsibility is to support life whenever there's doubt. Geriatric abuse. Any action on the part of an older person, of a person's family member, caregiver, or associated people that take advantage of the older person's person, property, emotional state, and emotions, sometimes sexual issues. The extent of elder abuse is really not known, and a lot of that is because these are people who aren't going to report their son, their daughter, their family members. Please try to obtain what you can in terms of an explanation. No different than dealing with pediatric abuse. What you're looking for is, does the story fit the bruises? And remember that bruises to the face are almost never the result of accidental trauma. They definitely have a high index of suspicion there. Also in the creases of the body, between the buttocks, cheeks, under the arms, in the groin. All of these areas should make you kind of wonder, how did they get traumatized here? It's estimated, and only estimated, that about 1 in 6 cases ever gets reported, if even that many. Information that may help are repeated visits to the emergency department, stories about older folks being accident prone, and soft tissue injuries in various states of repair. Now, this may be complicated by the fact that they may be on anticoagulant medication, which makes them look bruised almost all the time. So try to get a good history, but always have just a little bit of an index of suspicion that many of our older patients, unfortunately, are not getting the care and attention that they probably earned from their years. And another thing that's kind of associated with this, too, is retribution. Sometimes the victim was at one time the abuser. Probably the most frequent type of abuse is neglect. I remember one of the worst calls I went on was a patient who had actually been shut into a small casita in the back of their house, and they actually had the windows and doors nailed shut with boards while the family was away for the weekend. I didn't want to have to worry about the older family member getting out of the house and causing havoc in the neighborhood. So they just thought they'd just board them in and make sure they left plenty of newspapers on the floor, so if they couldn't get to the bathroom, they had a place to pee. Other cases of elder abuse are people who actually take advantage of the confusion that older people might have with ordering things on the internet or managing their money. Sometimes managing their insurance, their ability to get prescription medication may be subverted, and people will actually be abusing the medication that was intended for the older patient. And that brings us now to psychiatric issues. One of the big ones that we want to think about with patients who are older is there's a lot of issues that can go with that and that can cause that. Often it's after financial concerns have become more of an issue, loss of a loved one, dissatisfaction with living conditions, or with their own independence. Depression is a common disabilitating order, and while it affects 2 million older Americans, it is frequently underdiagnosed in the elderly. It is not a normal part of aging. I think I've already gone over some of the risk factors. Probably what we should not overestimate is that, particularly with older men, it's associated with suicide rate. In fact, older men have the highest suicide rate of any age group or any group in the United States. These people choose to use a lethal means, and they're not trying to get attention, they're just trying to leave. Suicide is often predisposed by death of a loved one, by illness, by feelings of hopelessness, could be part of an alcohol abuse dependence cycle, and could also just be because of a loss of meaningful life role.
Tom, 3 things to remember when you get older. Never pass up a bathroom. Never waste a hard on. And never trust a fart. Keep that in mind as I approach decrepitude. Good.
This is Danny Burrell. I hope you have found this presentation informative and useful. The next and last part of it, we will give you a whole lot more to know about getting older. Good things. As always, let me know if you have any questions. You can contact me through Canvas.